In the late 1960s, psychiatry was experiencing a turbulent period of transition. Psychiatric hospitals still carried the heavy legacy of the asylum institutions of the previous century. Large buildings isolated from society, long hospital stays, diagnoses that seemed definitive, and an environment where the doctor's word was almost considered law. Psychological science, however, was beginning to question this structure. New therapeutic approaches, new theories of the mind, and increasingly strong criticism of how decisions were made about who was considered ill or healthy were emerging. The central question was simple but devastating. How much can we trust psychiatry's ability to accurately identify who is truly experiencing a mental disorder? Not just in theory, but in the real world, in the hospital, in the doctor's office, in the decisive moment when a doctor looks at someone and assigns a label that can change their life forever. David Rosenhan, a psychologist and professor, felt the weight of this question directly. He observed something that many also suspected, but few dared to say openly. Psychiatric diagnosis did not always seem to be an objective discovery, but often an interpretation influenced by context, environment, and the professional's prior expectations. Rosenhan wanted to test not books or theories, but the system itself functioning in its most concrete form, clinical practice within hospitals. Before beginning his experiment, he formulated two crucial questions. Can psychiatrists distinguish between mentally healthy individuals and those with disorders when both present in an institutional setting? What happens to the perception of a person's behavior after they receive a diagnosis? Does the label transform the observer's perception? These questions were not philosophical. They had real human consequences. Once labeled as mentally ill, the individual carried that title in documents, reports, interactions, and often in their own self-image. Society does not always differentiate between diagnosis and identity. Rosenhan knew that to test this, he would need to go beyond academic debate. Analyzing medical records or observing patients wasn't enough. It was necessary. Enter the system from the inside, to live it, to feel its dynamics, its pressures, its blind spots, its automatic behaviors. It was necessary to put healthy people in there and see what happened. If the system was reliable, it should recognize that they were healthy. If it wasn't, it would fail. This point is crucial to understanding the strength of the study. Rosenhan didn't want to prove that diagnoses never work. He wanted to know they work when the context is uncertain, when the only symptom presented is subtle, when the doctor needs to interpret more than measure. He wanted to know to what extent psychiatry was based on solid criteria or on interpretations permeated by culture, expectation, and institutional authority. The world of psychiatry, until then, worked with classifications that seemed definitive. Terms like schizophrenia, psychosis, or neurosis carried almost absolute weight. Receiving such a diagnosis was often a long, sometimes lifelong sentence. Rosenhan asked what no one wanted to face. What if part of this process is based on biased perceptions, expectations, and social constructs, rather than an objective understanding of the human mind? This question sparked one of the most uncomfortable and provocative experiments in the history of psychology: the secret plan of the pseudo-patients. To answer questions that could destabilize the entire psychiatry of the time, Rosenhan needed more than theory. He needed a real test. Not a simulation, not interviews with doctors, not retrospective analyses. He needed to enter the system from the inside, like someone walking silently into unknown territory. His plan was as simple as it was audacious. Send perfectly healthy people to psychiatric hospitals and observe what happened. These people became known as pseudopacientes. There were 8 volunteers, including Rosenhan himself. They weren't actors, nor individuals trained in sophisticated deception. They were professionals and ordinary people, psychologists, graduate students, a pediatrician, a housewife, people with no history of mental disorders, living their lives normally. Each was instructed to act naturally, without inventing complex stories. Only one detail would be changed. At the time of admission, they would all report the same symptom. A single, carefully chosen element. Hear a voice who spoke vague and symbolic words, such as empty, hollow, tick-tock. No delusional narratives, no mystical visions, no disjointed discourse. Just a small, almost minimalist indication, which is often considered a possible marker of psychosis. Everything else would be absolutely true. Name, profession, life history, family relationships, everything stated precisely. This was crucial. Rosenhan wanted the boundary between sanity and illness to be tested cleanly, without theatrical distortions. Once admitted, the plan changed. They should stop pretending completely. They would act like any normal person in their daily routine. They would talk to other patients, ask about schedules, read books, walk down the hallways. If asked, they would say that their voice had disappeared. There would be no new symptoms, nor attempts to maintain the charade. From that moment on, the test was not about feigning madness, but about to observe how the hospital would interpret normality. Meanwhile, each pseudo-patient recorded everything: how they were received, the nurse's gaze, the time spent interacting with psychiatrists, the comments noted in their medical records, their reactions to simple questions or attempts at human contact. These records, however, needed to be kept discreetly, as writing in the hospital could be seen as symptomatic behavior. The act of writing in itself could be interpreted as a sign of paranoia, obsession, or detachment. That was the central point of the plan. If the system were robust, it would recognize the absence of disease. If it were fragile, it would label normality as pathology. And then the pseudo-patients were sent, each one to a different hospital, public and private institutions, modern and traditional, in various regions. This broadened the scope of the experiment because it wasn't a single hospital with questionable practices, but a distributed test of the institutional model of diagnosis itself. They entered silently, without announcement, without witnesses. Just ordinary people passing through heavy doors that, once closed, rarely opened quickly again. What happened inside would reveal more about psychiatry than any book or speech. The shocking result: when the fake patients crossed the hospital doors, something unexpected happened. They were all admitted. There was no hesitation. There was no doubt. The mere mention of hearing a voice, without significant behavioral changes, was enough for psychiatrists to quickly arrive at serious diagnoses, such as schizophrenia or manic depressive psychosis, depending on the institution. None of the professionals questioned the possibility that those people might be mentally healthy. The diagnosis, once established, redefined everything. Inside the wards, the pseudo-patients began to act normally. They walked around, talked to other patients, asked polite questions of the nurses, read books, and tried to maintain a healthy routine. But every gesture, however trivial it may seem, it began to be reinterpreted through the lens of applied diagnosis. When a pseudo-patient recorded their observations, something perfectly rational for someone participating in a study, the behavior was recorded as compulsive writing or patterns of obsessive recording. When they tried to converse in a cordial and direct manner, the initiative was described as attention-seeking behavior, typical of schizophrenia. It was as if the diagnosis had become a permanent lens. Everything observed from then on served to confirm the presumed disease. This point is crucial because it exposes a deep psychological and institutional mechanism. The label not only describes, it comes to create the meaning of the behavior. Furthermore, the pseudo-patients discovered something else disturbing. Human communication within institutions was minimal. Nurses walked through the corridors without looking you in the eye. Psychiatrists showed up for only a few minutes a week. Real patients tried to talk, but were often treated as if their words were automatically divorced from reality. There was a feeling of depersonalization. They were not seen as a person, but as a case, a diagnosis, a walking medical record. The hospitalization lasted longer than anyone expected. Some pseudo-patients remained hospitalized for 1 week, others by almost 2 months. None were released quickly, even when they claimed they no longer heard voices, even when their behavior was entirely consistent. When they were finally discharged, they were not declared healthy, they were registered as schizophrenia in remission. In other words, even after a full recovery, thalidomide remained. The label remained attached to the ID. This meant something devastating. Once diagnosed, the individual is no longer just someone who was going through a state. They become someone. What is that one? This phenomenon is known as labeling effect. The psychological diagnosis begins to shape the perception of everyone around, and often also the self-perception of the individual. Rosenhan concluded that what he witnessed was not merely a failure to identify sanity. It was a much broader and deeper revelation. The hospital environment had the power to transform any human behavior into a symptom. The institution did not just treat patients, it produced the idea of illness. And he did this not through neutral observation, but through interpretation guided by expectation. Rosenhan's experiment revealed something too uncomfortable to ignore. It is not only the patient who is observed, it is the institution that shapes reality. If an institution can transform the sane into the insane in everyone's eyes, what does that say about how we define normality, deviance, and identity? That was the first impact. And there was a second one to come. The counter-experiment, the reverse error. The initial study had an immediate impact. Hospitals, psychiatrists, and academic institutions reacted with unease. Many refused to believe that experienced professionals could have failed so spectacularly. Some argued that Rosenhan had been unfair, that his pseudo-patients had been too convincing, and that the diagnoses had been adequate given the available information. In response to these criticisms, Rosenhan did something even more disturbing. He made a second move, simple and devastating. He contacted a large, renowned hospital and informed them that, in the coming months, he would be sending in fake patients to try and get admitted. He asked the staff to identify who among the new patients was an imposter. The hospital accepted the challenge with confidence. Psychiatrists, nurses, and directors began carefully examining each person who arrived seeking help, looking for signs that they were being deceived again. For weeks, the atmosphere in that hospital changed. Suspicion hung in the air. Every gesture was examined. Each sentence was analyzed. Each patient was previously viewed as a potential intruder rather than someone asking for help. The result was surprising. The hospital began to register a large number of suspected pseudo-patients. Real people who were there in genuine distress were classified as likely imposters. Doctors wrote reports stating they had high confidence that certain individuals were trying to deceive the staff. But there was one detail that would transform this episode into an even stronger accusation against the system. Rosenhan had not sent anyone. No pseudo-patients, no volunteers, no simulation. All that movement, all those assessments, all those suspicions were generated based on expectations. This meant something monumental. When the system is pressured to find fake patients, it finds them. When the system is pressured to recognize a disease, it diagnoses it. i.e., the diagnosis wasn't just in the patient, it was also in the eyes of the observer. This second movement revealed the other side of the mistake. In the first experiment, the hospital via disease where there was none. False, positive. In the second one, the hospital began to see feigned sanity where there was no pretense at all. False, negative. The problem then was not just the ability to identify disease. The problem was the stability of the diagnostic criteria themselves. Psychiatry wasn't failing on a single point. She was oscillating between two extremes: credulity and paranoia, naivete and suspicion, blind trust and total distrust. What Rosenhan demonstrated with surgical precision was that when diagnosis depends on subjective interpretation, expectation, and context, the very line between illness and normality becomes malleable. That conclusion was dangerous because he didn't attack a hospital. He wasn't attacking a doctor. He wasn't attacking a technique. She attacked the foundation from the diagnostic authority. If the gaze can create the sick, then who defines what sanity is? And even more disturbing, if the diagnosis can be constructed, it can also be tax. That was the moment when the debate ceased to be purely clinical. He became ethical, philosophical. political, and human. The power of labels and expectations. When Rosenhan analyzed everything his pseudo-patients had experienced, one conclusion became impossible to ignore. It wasn't just the diagnosis that influenced the experience within the hospital, it was the label. The word assigned to the patient upon admission was not simply a clinical term. It became a lens, a frame, a kind of invisible filter that transformed every gesture, every silence, every expression. A person diagnosed with schizophrenia was no longer seen as someone who could be reading, observing, resting, or simply living their own time. Every act was interpreted as a sign of the illness. Walking could be motor agitation. Silence could be affective withdrawal. Asking questions could be manipulative behavior. Writing notes could be obsessive thinking. Even what, in any other context, would be called attention, education, or curiosity became a symptom within the hospital. Rosenhan realized that the issue was not simply whether the diagnoses were right or wrong, but how they reorganized reality after they were applied. The label didn't just describe the patient, it created in the eyes of those who observed him. This phenomenon is known as labeling effect. Once a label is applied, behavior ceases to be interpreted based on who the person is and begins to be interpreted based on what is believed that person to be. The diagnosis becomes a narrative that precedes the person. It becomes more real than that person's own experience of themselves. Within the observed hospitals, doctors and nurses rarely interacted deeply with patients. Many rushed through the corridors, avoiding eye contact, as if distance were part of the job. This created an atmosphere in which each individual lost their uniqueness. It was no longer John, who likes to read, but the schizophrenic in bed 12. It was no longer Mary, who is sad because she misses her family, but the depressed woman with an interpretive tendency. That depersonalization, it was perhaps the most violent part of the process. The patient ceased to be someone with a history, intention, and meaning, and became a walking diagnosis. There was no room for nuance, for complexity, for humanity. The label functioned as an absolute summary. Rosenhan stated that this did not mean that psychiatry was inhumane by nature, but that the institutional context could, to produce dehumanization without anyone needing to want it. The institution's structure shaped perspective, routine shaped judgment, haste shaped perception. There's a point here that requires caution. It's not about denying real psychological suffering. People face profound, painful, and legitimate disorders. The question is different. It's how the institution responds to this suffering. It's about whether she recognizes the individual or erases the individual to deal only with the label. Rosenhan's experiment revealed something that goes beyond psychiatry. It showed a universal aspect of human nature. We see what we believe we are seeing. Expectation shapes interpretation. Meaning comes before observation. When we call someone crazy, weak, useless, problematic, unbearable, difficult, or dangerous, we are not just describing that person. We are contributing to the way it will be perceived and treated. We are, in a way, constructing her identity from the outside. What's most unsettling is that often the person begins to internalize this gaze. What was once an external label becomes an internal narrative. They start to think, maybe that's really who I am. Rosenhan clearly shows us something that resonates deeply. When the world decides who you are, it's hard to remember who you were before. And that explains why the diagnosis given to the pseudo-patients didn't disappear even after discharge. They were released, but not as healthy people. They were released as schizophrenics in remission. The label remained, even when the symptoms had never existed. The label is a brand, and brands, when accepted as identity, become silent prisons. Legacy, limits, and the question that remains. When Rosenhan's study was published, it struck the heart of modern psychiatry like an earthquake. It wasn't just an intellectual critique. It was a clear and uncomfortable public demonstration that the system that claimed to be able to distinguish between sanity and madness was failing. It could fail profoundly, And more than that these failures were not exceptions. They were structural, rooted in the way we interpret the human mind. The reaction was immediate. Conferences, debates, articles, protests, defenders and opponents clashed in academia and the media. Some psychiatrists responded with indignation, claiming that the experiment was unfair, artificial, and that no one ever diagnoses based solely on a single complaint. Others, however, recognized something they could not ignore. The study had exposed real vulnerabilities. This impact contributed to one of the greatest reforms in modern psychiatry, the creation and subsequent consolidation of DSM-13. In 1980, Rosenhan introduced much more specific and standardized diagnostic criteria, attempting to reduce the scope for subjective interpretations. Directly or indirectly, Rosenhan helped push psychiatry into an era of greater rigor and greater attention to method. However, at the same time, serious criticisms of their work arose. Some questioned the small sample size of pseudo-patients. Others claimed that the hospitals visited were old, underfunded institutions with outdated practices. There were those who argued that what the experiment showed was not diagnostic failure, but the vulnerability of trying to simulate mental symptoms in a clinical setting. And there were also, rightfully so, ethical questions. Was it right to deceive professionals? Was it fair to occupy slots and time that could have been used for real patients? These criticisms matter. They prevent the study from being treated as absolute truth, but none of them negates the power of what the experiment revealed. The central question remains: to what extent are our identities shaped by how we are perceived? If a doctor, an institution, an authority figure defines us as something sick, unstable, fragile, dangerous, incapable, how long until we start to believe it, or until others around us begin to act as if it were true? Rosenhan's experience shows that a symptom is not necessary for a person to be treated as ill. Sometimes just a label, a word written on a piece of paper. A diagnosis that may have arisen from a moment, a misunderstanding, an interpretation, and when society validates that label, it becomes almost irremovable. Yes, we're talking about hospitals, but we're also talking about schools, companies, families, social groups. The same dynamic appears when we call someone problematic, slow, difficult, dramatic, aggressive, cold, anxious, or overly sensitive. Labels produce reality. They shape expectations. Expectations shape behavior. And behavior shapes destiny. This is the most profound point of Rosenhan's legacy. The line between being seen and being defined is terribly thin. And perhaps the most unsettling question is not what the study revealed about hospitals, but what it reveals about us. How many times have we seen someone not as they truly were, but as we believed them to be? How many times has this been done to us? And how many identities, stories, and lives were written in this way without anyone noticing? In the end, Rosenhan's legacy is an invitation, or perhaps a warning. Before judging someone, remember that your perspective is never neutral. She carries with her her context, her beliefs, her expectations, her stories, and sometimes she might just be wrong. The study ends, but the question doesn't. Who are you when no one is looking at you through a label?